Hi. Hello guys. So today I'm recording a video and this video is going to bring a lot of smiles to your face because it's one of those complicated topics, the TMJ. And I know it gets complicated, first of all, to properly understand what is disk reduction, open reduction, close reduction, and especially which splint to use after that. Though I know I have made a previous video uh, giving a lecture in detail about the TMJ, but it just clicked me today to further simplify this. And the moment I have made a very short paragraph upon the simplification of the splints, in which case to use what, and I have shared it on my enrolled candidates group and the Facebook group and the Telegram. Everybody is so happy because this is what they needed, I guess. And I'm myself surprised why didn't I think of this before. But anyways, now that it's there, let me share it with you. And after listening to this presentation, for sure, for your entire life, your concepts about your TMJ, the diagnosis, and which splint to use when would forever be cleared. And you don't have to open your textbooks or go in detail, unless, of course, you want to understand and research about it more. But at least from the exam perspective, your knowledge would be clear. And no matter how many questions anybody shoots you regarding the TMJ and which splint to use when, you'll be sorted. So let's start. So I have divided this presentation into the proper SBQ that I'm going to solve today regarding the TMJ and a little short YouTube video about how the basic anatomy works and what is basically delayed reduction, what is a locked jaw, what is disc displacement, and then I'm going to talk about the splints. So let's cover this quickly. The question is a 33-year-old athlete patient. Athlete is important here. That means this patient plays sports. Sports can be high intensive things which can result in high intensive injuries, high impact injuries, damaging injuries. So that's why athlete patient is mentioned. They could have otherwise mentioned any other patient also. Now, this patient had suffered a blow to left jaw during her childhood while playing sports. Now, always remember, whenever a person has suffered a jaw to any bone in the body, it's a very traumatic thing because any damage to the bone is very painful. Any one of you ever had a fracture, you know how damaging and destructive mentally it can get, and then the recovery process is also so long, and sometimes you may not actually get 100% of the function back, and any memory of that trauma would trigger the same pain that you may have experienced. This process of reliving the same intensive pain that you had when you had this trauma to the bone, any bone, is called as a post-traumatic stress disorder. And you may try to avoid any memory of it by not going to that particular place or not talking about it because you may get the same physical symptoms. So always remember, whenever a question is asked where a person is into sports and they had had an injury, somewhere the post-traumatic stress disorder question is going to pop up. Okay, that's why I was explaining all this. Now, she presented at your clinic complaining of pain and TMJ, closed momentarily. When opening her mouth during the clinical examination, she had pain and deviation on the left side of her TMJ. So definitely some TMJ issue is there, plus there's a history of trauma. Pain was radiating to the ear. She was having difficulty chewing on the left side and hence got accustomed to eating on the right side. Recently, not always, she has noted that her jaw click and gets momentarily locked for a while when she is yawning for 30 seconds. So if there is a long yawn like that, when the bone opens, it gets locked. Locked means you cannot close it back and then slowly it goes back into position. So if she opens her mouth wide, basically, the jaw gets locked. Now, whenever there is any mention of the jaw getting locked while opening or clicking, it means something has to be related to the disc. You understand? The TMJ question I can divide into two parts. One is the disc related questions, where the question will mention that the patient has either a limited mouth opening, or the jaw gets locked while opening, or there's a click. Immediately your brain should go to disc problems. Second TMJ problems are the patient is having bruxism and there is pain in the morning when you get up, and there is muscular pain and there is clenching of teeth. So these are the only two questions that will be asked in your exam. And these two questions have their own specific treatment. So there is no way you're going to get confused. So whenever there is something related to the discs, the answer will always be anterior repositioning splint. Regarding reduction of the disc, we'll come to the diagnosis later, but just remember, whenever something is related to the disc, the type of splint that has to be used is always a anterior repositioning splint. Whenever there is bruxism, clenching of teeth, the answer is Michigan splint. I'll tell you later how we work onto it. So that is it. The another two types of splints are morning repositioning splint and the mandibular advancement splint. The mandibular advancement splint is basically getting a mandible ahead, and that is used for obstructive sleep apneas. So if a question is a patient is having snoring and obstructive sleep apnea, which splint you're going to give? Mandibular advancement splint. Morning repositioning splint is to be given when you have to make the mandible go back into its centric relation. See, for example, if you get a patient who had a lot of crowns and bridges, and now they are all worn out, discarded, or you have to do a full mouth rehab and the occlusion has changed. So you want to set the mandible to a certain centric relation before you actually record it. So you'll ask the patient to wear this morning repositioner splint. I'm going to show you pictures of all so you finally memorize that, and I'm going to revise this again. I'm just giving you a gist so that now when we are going to read the question again and understand the TMJ anatomy, you will know what I'm talking about. So anyways, let's go back to the question. So here, this question specifically is a disc-related question, okay? Somewhere later in any other SBQ, if I come across the clenching, I'm going to make you remember that I did discuss that TMJ questions are divided into disc and bruxism. This is a disc-related question. Now, before we proceed any further, let us just brush up. If your TMJ concept is good, great, still listen to this video. If you have lost connection, and just remember that TMJ is a gangliomo-arthroidal joint with a fibrous disc, and that's all you know about, do watch this video. So let's go. I found a very beautiful video about the TMJ. Let's understand the basic
Mandibular
anatomy
joint,
first.
the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 mm opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, The retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction.
So I'm going to pause here. You understand, whenever the condyle is moving ahead over the articular eminence and the disc has also completely moved, and after the disc has moved, the condyle is moving, but it's still coming on top of the disc, it's called as width reduction. Okay, width reduction. You remember this image, the condyle is still below the disc. Now let's go back.
In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction.
So now if you see, the condyle is behind the disc. This is called as without reduction. You need to remember these two images. So if somebody says I'm having a clicking, but my jaw is not getting locked, that means the clicking is happening because the condyle is having friction with the articular eminence, but it's still coming below the disc and there is no pain. Usually clicking doesn't cause pain. That is width reduction. But when the condyle, like this image, is behind the disc and there is limited mouth opening and then there is pain, which is the symptomatic part of the problem of the TMJ, it is without reduction. So condyle below the disc, everything ahead anteriorly is with reduction. Disc is here, condyle is behind, without reduction. You need to have these two concepts clear in your mind, and this is a very good video. If you want, pause it again, see it. Now let's go ahead.
Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
So I hope this is clear. Now let's come to the treatment part of it. So whenever there is a disc problem, what did I say, which is the splint that you're going to give? It's called as anterior repositioning disc. Now you see this? Now this splint is always present only on the anterior teeth. It can be either the upper anterior or the lower anterior. I want you to focus on this image. Now when it's also called as a small jig, I had a bit of a clicking. So my own OMDR specialist made a small jig-like thing, which I never wore. That's another thing. Because I was not used to it and my clicking then somehow just went away. Maybe I was stressed out a bit or something and that's why the clicking had appeared. So anyways, I know this jig because I used myself. So this is a small, this tiny. You may feel you're going to choke on it, but you don't because it's adapted according to the anatomy of your anterior teeth. And once you click, it kind of sets into position. I can't find where's my jig, otherwise I would have shown you here itself. So what you do is you basically wear it and your lower teeth are resting on it. So when you're going to sleep, the posterior teeth are not in contact at all. And because you get like this, a bit, your jaw, the bone out here is released from its socket for a while. So the area out here gets to rest basically. And over a period of time, the body heals itself. Like we saw in the video that in majority of the cases, the retrodiscal tissue itself converts into the disc. it becomes avascular so that no pain is felt. Because see, there is temporal bone, there is this the head of the condyle. They cannot have friction, otherwise pain will happen. So the disc has to be there always. So that is the anterior repositioning splint. The question, whenever it mentions anything about the disc, clicking, locked jaw, and any disc related problem, limited jaw opening or clicking, I already mentioned, right? The answer always, always, always has to be anterior repositioning splint. Remember this. Now I come to another concept of TMJ, which is this.
If the jaw joint stays in place. From this information, a final treatment can be formulated. Bite and jaw joint work together. As the mouth opens, notice how the jaw bone rotates in the joint but stays braced against the skull with the cartilage disc cushioning between the two bones. As Sue closes, notice how the jaw rotates back, staying braced and cushioned at all time until all teeth come into contact at the same time. At the end of the chewing stroke or opening and closing cycle, all the teeth have come together into the bite and the jawbone and disc are braced against the skull. What would it look like if Sue had a bite problem? Her jawbone starts off braced in the joint, but as she closes, her teeth come into contact prematurely in the back so that in order for the rest of her teeth to come together, her jaw has to come out of its socket, down and backward to avoid the early contact, which can be damaging and painful to the teeth. This is why we say that Sue has an unstable joint and is not braced throughout the opening and closing cycle. During the daytime, Sue's brain programs her muscles to make sure that the bite always comes together evenly, avoiding the early tooth contact in the back of the mouth by keeping the jawbone out of the joint socket. During sleep, the brain wants to rest and not worry about constantly programming the muscles, so instead it tells the muscles to either clench or grind the teeth so that they stay locked together. The jaw stays out of the socket all night and the muscles of the head and neck are working constantly during sleep. Since these muscles get overworked every night, they become fatigued, leading to spasms and inflammation. The result of the chewing system being constantly overstressed is breakdown of the teeth, gums, bone, and joint, and finally pain such as headaches and migraines, neck.
Basically all the symptoms of bruxism, clenching of teeth. Now in this, we are not having any disc problem. This is a proper joint issue because of some occlusal problems, bite problems, eventually migrating itself to becoming a muscle problem and eventually pain out here. Now in this scenario, you will give something that will prevent the teeth to come into contact prematurely, or prevent the teeth to come in contact at all. So you will fabricate a splint, a thick splint. It's called as a Michigan splint, and I'm going to show you how it looks like. So this is a Michigan splint. Yeah, it's kind of your night guard, but night guard is flexible. This Michigan splint has to be 2 to 3 mm thick. The teeth are absolutely not going to be on contact. So Michigan splint is going to cover all the biting surface of the teeth, all of them, unlike the anterior repositioning splint, which covered only the anterior teeth. Understanding the difference? Two different problems of TMJ and two absolutely different solutions. So that is Michigan splint. This is anterior repositioning splint, anterior repositioning for disc problems, Michigan splint for bruxism. Understood? Now I will show you the morning repositioner. Now, the morning repositioning splint, like I mentioned, a full mouth rehab comes to you, and there is no all the teeth have become flat, so there is no centric relation occlusion happening out, and you have to give a properly full mouth prosthesis. So you need to have a centric relation, and the centric relation would have changed because all the teeth are treated. So now you have to program the patient to bite in a centric relation, and to program he needs to get into a habit, and for that the splint is going to come in use. So in this splint you see there is a bite only on the premolar area. So when the patient bites, it kind of makes the jaw go into a position that you want to go into. So you take all the measurements and you fabricate that, A general dentist never does this. It's always the job of a prosthodontist who's going to do all this. But you should know about this splint as well, because in one of the options, they are going to mention this splint, and so you should not get confused. And the last splint is the mandibular advancement splint, which is used for sleep disorders. It just gets the mandible a lot ahead so that the airway opens up a bit and the posterior part of the tongue is not falling behind, and all other theory which you can of course google up how the splint works. So these are the four types of splints, and I hope after this video that I have explained, now when we are going to solve the question, you will know what you are answering, right? So let's go back to the question again. We have a 33-year-old, an athlete patient, had a trauma to the left jaw while playing. Right now, the problem is her jaw is getting clicked. See, I'm just taking out the keywords. Yesterday, only one of my candidates messaged and said, Doctor, I'm solving all the mocks, and yet I overthink the question and make a mistake. You're not overthinking, you're not reading the question properly. You're reading everything in the question. No, you just take the keywords. What keywords I'm choosing from this question? I read the question completely once. The second time when I'm reading, I'm not reading, I'm analyzing. There is a difference when you read, there is a difference when you analyze. Okay. So now I'm analyzing. What am I analyzing as to what are the keywords? Keywords, athlete, there is a trauma, possibility of a post traumatic disorder. My mind should function this way. Right now, what is the problem? The TMJ is deviating on the left side. Fair enough. There is pain present, so there is a symptom. Difficulty chewing on the left, so she's chewing on the right. Okay, not relevant to me at the moment, but I'm going to keep that in the back of the mind. Recently, that word recently is very important to me. She has noted her jaw clicks. The moment I read the word click, that is my red highlighted keyword, disk problem. That's it. So now my mind is going to function everything related to the discs and gets momentarily locked. Okay, while opening, they did not mention there is limited opening, so it's reduction with reduction. Okay, the disc anterior positioning is there because the click can only come if there is an anterior reposition with reduction. If they would have mentioned the patient feels there is limited mouth opening, I would have said without reduction. So I already know the diagnosis by reading all this before even I proceed to the sub questions. Now, with all these things in my mind, I'm already set to answer questions on this. Now let's see what are the questions. What question from our history is the most relevant to lead you to a potential diagnosis? Currently, there is no problem happening in the TMJ because of any stress. The stress word is not mentioned because usually TMJ problem starts because of that. Bruxism is not mentioned. Clenching is not mentioned present before. Right now, signs of bruxism and attrition in the lower teeth are present. The patient has never visited the dentist before because it's not mentioned in the question. So everything I'm going to take it as recently happening. Now let's see what are the options present. History of autoimmune degenerative disorder in the family. The question has not mentioned that, so I'm not going to go with that. Anxiety, depression. Well, it is a stressful situation having a trauma in the childhood, but I'm just going to keep this option a little lower in my priority list. Post-traumatic stress disorder. That's going to be my top priority. Osteoporosis, no. Stress. If stress is there and post-traumatic stress disorder was not there, I probably would have chosen stress or depression as one of my option. But because post-traumatic stress disorder is mentioned, as I was mentioning this in the start of my video, that whenever there is a trauma history and an athlete is there, usually post-traumatic stress disorders are there. I'm going to go with that option. And I've given here a good feedback about it. Please read. Second sub question. Which splint to give? Now you should be answering this question. Michigan splint. What is a Michigan splint? That image of teeth covered, all the teeth, the occlusal surface covered with the splint should pop up in your head and it should lead you backwards towards bruxism. The question does mention that the patient is having bruxism, but what is the main problem? Clicking. So I'm going to go with the disc part, not the bruxism part at the moment. Mandibular advancement splint is for sleep apnea. So out of Michigan and mandibular advancement, out of question again. No splint, No, that's not a right answer. Morning repositioning splint, we discussed it's for defining the centric relation. Anterior repositioning splint, which is there for the disc reduction, right? So now when you read, you're not confused. At least I am definitely feeling very happy having all these concepts so simple and crystal clear. So again, I've given a long feedback, and that entire feedback I've shortened into a small paragraph, and I've already shared on my Facebook Target ADC group. Okay, so in case you wanna go and just copy paste that paragraph into your notes to study, do that. What is the condition the patient is suffering from? Now they have come to the diagnosis. So what have we discussed? The patient is having clicking. Upon yawning, the jaw gets locked. There is no limited mouth opening. So whenever there is yawning and jaw is getting locked, it's with reduction. And it has got something to do with disc. Okay. So somewhere my diagnosis should mention disc displacement with reduction. Okay. So let's see. Disc derangement with delayed reduction, kind of right answer. Disc derangement without reduction, no. Disc derangement with immediate reduction, no. It's always a delayed reduction because the first 20 mm, like we mentioned in the video, it's just a rotational movement of the condyle. It's always a delayed reduction. Disc derangement with open close reduction. Open close becomes contradictory. If they would have just mentioned this displacement with open reduction, it's kind of a delayed reduction only. Then they would have become synonyms. But they mentioned open close reduction. It's not a diagnosis at all like proper one. So I'm going to go with option A. Why? We just discussed the entire concept. We saw the video. I hope this is clear. Now I believe TMJ will become a little more interesting to you all. Please go and read a lot of SlideShare PPTs on it, or you want to download an article about the basic anatomy, the disc problems in the TMJ. Or you know what? It's fun, if you just type on YouTube arthroscopy of TMJ. I've seen one live. A speaker was presenting and he had recorded a live video of it. And it was absolute, what do you say? Delightment to watch it. Like I could never imagine the disc, the actual thing, how it looked, and the blood vessels going around. It was a beautiful video, and we were like 20 of us in the room, and there was a pin drop silent because nobody had ever seen how the TMJ from inside looks like with a small camera. I'm sure there are YouTube videos upon it. So pause this video, go drown yourself in TMJ today and emerge in full happiness understanding the concept. Even if you may not be doing anything of this, but in future, if you meet any of your colleague or some patient comes with a diagnosis like this, you know what they are talking about. So yeah, I think the battery of my laptop is gonna go low. Let's quickly finish. Best radiographic investigation of TMJ, always MRI. It's a joint and there are discs involved. Discs can always fibrous tissue, soft tissue, MRI. Okay. And in a few weeks' time, the patient complains that you did not treat it right in the first place, and now they have ended up with limited mouth opening. So what do you do? Well, it's an ethics question. Do you refuse to talk about it? No, you can't do that. Tell him to complain if you can. You're not going to provoke the patient, right? Try to explain what happened and record. Try to explain that you're trying to help and maybe this is the part of the process, or let's see what is happening. Let's do further diagnosis or refer to a specialist, whatever. You have to communicate to the patient. Contact your indemnity insurance. No, you're always going to talk to the patient first. That is the first ethics. And then later on, maybe if you feel the patient is going to complain, then you can contact your indemnity insurance. But you're going to explain to the patient, you're going to record that. Even me, whenever a patient comes and, example, today I have to debond the braces and we are done with the treatment, but the patient is like, no, I want to keep it for a month more. My friends are having it. I want to remove it with them. And the parents are like, doctor, let's just keep it for a month more. I recorded in my notes that the treatment is over and we are ready to debond, but it's on the patient's request there. We're keeping the braces on for 1 month more time. Everything has to be mentioned. If the patient refuses an extraction and it's going to lead to more problems, but they just want to delay it by 4 more days, you document that in the notes and you talk to the patient. So that should be the right answer. I hope this was a fruitful session for you all, and do write in the comments if actually your TMJ concepts got cleared, and if this video added even a tiny bit of knowledge to you, or cleared some concepts, or helped you in the exam purpose. It's nice to hear from you. I take out time just to help you all. You all can also leave a comment to just let me know, connect with me. All right. So I'll go to work now. It's been 3:30 and it's a rainy day. I think I'm gonna take some time to drive. So have a nice day, guys. Bye bye.